Hi Darren, I'd like to spend the next couple of minutes talking about the clinical benefits of the functional vision head impulse test. Let's start with the fact that we now have access to multiple tests of the VOR function, such as the gaze stabilization test and the dynamic visual acuity test. Where does the fvHIT fit into this?
Yeah, so I think if we consider what we have now for functional VOR testing, so DVA, we are looking at the visual acuity at a constant head speed. GST, we're looking at the fastest we can move our head and still maintain visual acuity. But both of those tests are just side to side. They're not canal specific tests, and you would almost call them a sinusoidal head movement. Functional vision head impulse testing is conducted in the plane of the semicircular canals, so has a much stronger correlation, you would think, with the physiologic VOR response through vHIT. So now we're actually looking at function during the paired responses from the peripheral sensory system.
So you've just mentioned the vHIT test. fvHIT and vHIT sound incredibly similar. So how are they different, and should we be doing both?
Now, that's a very good question because, as we have seen, they are very similar in their description, but one is the physiological test. So, vHIT, as we recognize it, is really just looking at the behavior of the eye relative to the head movement. So, we're measuring eye versus head movement, and we get a value, a numeric value, and we call that gain. fvHIT, on the other hand, isn't really measuring the eye at all. What fvHIT is doing is it's measuring the functional status of the VOR. And what do we mean by that functional status? Well, we would assume that if the VOR is working correctly, it has the eye back in position so that visual acuity is maintained, and therefore the patient can call out the optotype. Why is that important? Well, we've seen in the research studies that there can be poor correlation between functional assessments of the VOR and physiological assessments of the VOR through vHIT. They correlate very well at the acute phase, so when a patient is unwell and not long after they've had an episode and the VOR is being affected, vHIT and functional vision head impulse testing give pretty much the same answers. But as we see vHIT gains improving over time, so some weeks and months after the vestibular event, we see that actually the difference between vHIT responses and the functional responses through fvHIT are different. And what that indicates is that although the gain may be improving in the VOR, the actual functional VOR still hasn't returned back to normal. And that would correlate then with some of the symptoms that patients still present, even when some of our physiologic results appear to be returning to normal. So difficulty with visual acuity, difficulty with dizziness, difficulty with head movement, for example.
It's interesting to hear that sometimes the results of these tests correlate, but in other patient populations they don't correlate. How can we use these results in clinic to help guide our treatment for these patients?
Well, I think one of the things to consider is why do they not correlate? And really the why comes down to what we're testing. So we've discussed vHIT testing as being this physiological VOR response, fantastic, see how the eye moves relative to the head movement. But what does that really tell us? Well, it doesn't tell us a lot about function, and that's really why we're talking around functional VOR as being much more informative. And function really is something that maybe changes independent of physiological reflexes, and we see this in the healthcare literature. So looking at the function vision head impulse test, we're really looking at beyond just the reflexive movement of the eye, we're looking at some of the cognitive and central nervous system components. So actually, good visual acuity isn't just about getting the eye in the correct position. We need to hold visual attention. We need visual processing during that head movement. So there is a time that central nervous system requires to be able to see things clearly. And then we have other factors such as anxiety or other cognitive changes that can occur in more chronic dizziness conditions that can still hold and impair that functional VOR. And that's something we wouldn't detect in a vHIT VOR. And that's reflected in the research. So if you look at research, particularly looking at people with triple PD, for example, or chronic dizziness, we see poor correlation between some of the physiological measurements of VOR function, such as fvHIT, and looking at DVA, GST, and fvHIT. So that will actually help us give some insight of why that patient might be still experiencing their symptoms. And then more importantly, what things as clinicians can we consider in relation to managing those symptoms so that we can improve their outcomes?